Good afternoon. Why don't we get started? We're expecting probably a record crowd with such a phenomenal topic and great speaker. It's really my pleasure to introduce Dr. Sandra Gompf. I'm sure most of you know her, but she's truly homegrown. She's a local woman who attended medical school here, then did her internal medicine residency with us, and then her infectious disease fellowship with us, and is on our faculty and heads up the infectious disease section at the VA hospital across the street. Sandy's been involved with the university since she's come here and served actually as president of the faculty council at one point as well. She also has a website, I guess it's Gompf's ID Pearls, basically, and is very involved with trying to help control amoeba as well. So we're delighted that she's going to give us this talk on such a timely topic, so when we read the newspapers and watch the nightly news, we'll have a better idea of what's actually going on. Sandy?
All right, thank you very much. All right, first of all, I know that I am not the expert in the room because things have changed about 4 or 5 times since the last time that I tried to put together this talk. So this is up to date as of yesterday. So, and we can't really go over Zika virus without attending to the other arboviruses. So I'm going to do a little overview of all of them first. So an arbovirus is just any virus that is transmitted by an insect, an arthropod. And the ones that we have here, the Culex mosquitoes, you're familiar with West Nile virus, and the encephalitis viruses that we have seasonally here. We're really going to focus on the Aedes species because those are the ones that transmit dengue and chikungunya and Zika virus. All right. So dengue has been around the longest of these viruses, and it's the most impactful of them globally, over 50 million infections per year. And a third of the human population lives in dengue endemic areas. So basically these viruses follow human population. It first arrived that we know of on the Western Hemisphere in 1981. And probably since we've had lots of time to study this virus, urban development issues, infrastructure issues, poor sanitation, increasing human population encroaching onto more natural areas have affected the spread of dengue virus and the mosquitoes. So one of the bigger factors probably that we might have to tend to here is mosquito control, and we'll talk about that in a few minutes. So before 1981, we didn't really see any laboratory confirmed dengue hemorrhagic fever. After that is when we've seen a terrific growth. So dengue, as you know, there are 4 serotypes that are very closely related. You can be infected again 4 times with the different serotypes. However, once you're through the torment, then you're protected. You won't be infected again. And the biggest concern with dengue, once you get reinfected, is the possibility of developing dengue hemorrhagic fever, which is mostly characterized by a severe capillary leak syndrome. And it usually happens around the time that the person is beginning to defervesce. And there are a number of reasons that are postulated as a mechanism for dengue hemorrhagic fever. One of the more recent ones is that memory cells from a previous serotype may be partially reactive to a subsequent serotype, and for reasons that are still unclear, it triggers a cascade, an immunological cascade that instead of being protective, it essentially causes overwhelming sepsis and capillary leak. Dengue is endemic in Puerto Rico. They've had several outbreaks in the last few years. We're not sure what's going on in Hawaii on the Big Island right now. So far, they've had about 300 locally transmitted cases, and we'll have to give it time to see what happens, whether it becomes endemic there. There has been some limited local transmission here in Florida in the lower Keys, based on antibody studies, serology studies of the population. 10% of Florida Keys residents several years ago had dengue antibodies. Chikungunya virus is a little different. It's an alpha virus, and it first appeared in 2013, following along the same paths as dengue from Africa and Asia in the Pacific Oceans and then here. And so far, since 2013, there have been almost 2 million suspected cases in 45 countries to date. The most distinguishing feature of chikungunya is very painful joints, the serositis. It's referred to as an epidemic polyarthritis. Chikungunya is a Makande word for that which bends up, and a lot of these people can't move. They feel horrible. They have swollen joints, and this polyserositis can persist for several weeks to months, and in some cases 2 years. And it may be associated with rheumatoid arthritis, either if a person has predisposition to rheumatoid arthritis, and that has an interaction with the virus itself. There have been some cases where a low percentage of people who develop chikungunya and have persistent symptoms beyond a year, they go on to develop rheumatoid arthritis. So which one started first? We really don't know. Chikungunya is usually relatively mild other than the joint pain. Most people tend to recover after several weeks and eventually don't have the discomforts, but rarely you can get neurologic symptoms, cardiac symptoms, hepatitis. There have been a few fatalities, fortunately very rare. In Puerto Rico, last year they had 198 cases, which is actually a lot better than the year before, where they had 4,000 cases, and we had 12 that were locally acquired here in Florida, related to travel, imported with travelers. So there's some improvement there. Zika virus is the newcomer, but it seems to have spread a lot more quickly in recent years than the others. It's been around since the 1940s that we've known about it in primates. Around 1952 or 1954 were the first known human cases in Nigeria, and it really has had sporadic outbreaks here and there, but recently it has evolved a greater tendency towards virulence in humans. In previous outbreaks, Zika virus has tended to follow chikungunya, whether that's related to which mosquitoes are there and which transmit. It's not very clear. It's just a pattern so far. All right, and one of the biggest outbreaks was in 2013 in French Polynesia. And that was the first sign that we were going to have issues. So Brazil last year, they had noted a significant rise in Zika virus cases, especially towards the middle of the year. And interestingly enough, they did test for other viruses, but there weren't a whole lot of co-infections. They can have co-infections, but there are very small percentages. We have local transmission of Zika virus now in Puerto Rico, in the Virgin Islands, and American Samoa. We have not had any local transmission on the U.S. mainland. So far, 3 cases that are sexually transmitted here in the U.S., all from travelers. And we've had, at least as of yesterday, more than 30 travel-associated cases have been diagnosed. And of course, that number is going to go up because now we're looking. One of the complications that has arisen is Guillain-Barré syndrome. And Guillain-Barré syndrome, 60% of cases of Guillain-Barré syndrome are caused by an infection, usually a bacterial or a viral infection. Some species are more associated with it than others. But this particular situation was a significant rise. So in French Polynesia, when they had that first big outbreak, they had 2,800 cases of Zika virus. And that was a good percentage of their population. And they noted a 20-fold increase in their cases of Guillain-Barré virus, of Guillain-Barré syndrome. And I don't have a number. I didn't find that published, but it was a significant number. And that was the first indication that we might need to watch it. In Brazil, last year they had 1,700 cases of Guillain-Barré syndrome. And it seemed to vary depending on the states, but there were several states that had maybe 100 and something percent rise. In Alagoas, they had a 500% increase. And what does that really mean? We don't know. Is it a combination of viral infections? Is it the Zika virus itself? It seems like it's probably the Zika virus itself, but everything is evolving. In El Salvador, as of a couple weeks ago, they've had 6,000 cases of Zika virus and 104 cases of Guillain-Barré syndrome, and 19 are still requiring ventilatory support. So it's a public health and economic issue. The thing that caused the greatest alarm, of course, is the possibility of microcephaly being associated with Zika virus. And the usual level of microcephaly here is 2 to 12 cases per 10,000 live births. In Brazil, they averaged 1 to 2 cases per 10,000 live births, even accounting for underreporting. And during this last outbreak last year, they found 20 cases per 10,000 live births. Since last October alone, they've had almost 4,000 cases of microcephaly. They've also noted intracranial calcifications and several other fetal anomalies that seem to be associated, and they're still gathering information on that. Brazil, they were the first to correlate Zika virus infection directly to microcephaly on pathology and PCR of autopsy tissue. So, and there's another case actually in sometime in the last week where they again identified Zika virus in autopsy tissue of an infant that died from microcephaly. So the association is there, and it seems to be getting stronger, and it's not necessarily associated with the other viruses that tend to circulate. And unfortunately in Brazil and probably most of these areas, this is affecting underserved areas, people that are poor, resource poor, poor access to health care, poor access to or education about birth control. So, those are it's going to be a huge economic impact. So, of course, last week, because of the rapid spread, the public health authorities, pretty much worldwide, did the right thing and responded much more quickly this time to this problem than we did to Ebola, which we learned a lot. So we're actually doing, I think, very well. We're getting ahead of the curve here. As of yesterday, We haven't had any cases of Zika virus reported. So far, 16 travel-related cases in Florida. No local transmission. So when you see a patient who has a syndrome, a dengue-like syndrome, you need to know about all of the viruses. So we're going to go over a little of that. Body fluids, it tends to be a question. Dengue virus, and all of them can be passed on perinatally. Sexual transmission only seems to occur with Zika virus, and it does not, it's male to female transmission. There's no documented case of female to male. There is a high level of virus in semen for at least 2 weeks, perhaps longer. They really don't know the duration. It's under study. But the viremia of Zika virus only lasts about a week, and semen it can last longer. Breast milk is safe, so breastfeeding is encouraged. Possibility of blood transmission may occur with Zika with chikungunya. Not sure with Zika virus, has not been documented. All right, an antibody is protective for chikungunya virus as well as dengue virus. Zika virus, we don't know. All right, there were some documented PCR positive blood donors in French Polynesia. So there's that concern. Now, when you evaluate the patient who comes in with fever, rash, and body aches, two things that we need to be discussing with every person that we evaluate for the first time in HMP. We need to ask about travel history. We need to ask about vaccination history. In this case, if the person has traveled within the last 2 weeks or has been residing in an area with transmission of these viruses, you also need to ask about possible exposures to malaria. Consider leptospirosis, measles, syphilis, even in a traveler. Parvovirus, there are a lot of viruses and syndromes that can cause fever after travel to these areas. Vaccination history, measles. We have more and more young adults who are growing up unvaccinated. We have a lot of travel back and forth, so it's important to know vaccination history. They could have measles. All right, this might be a little bit hard to read, but just to compare the three viruses, the similarities. Dengue and chikungunya virus are both transmitted by the Aedes aegypti and Ablopictus species of mosquitoes. And we have those here in the southeast of the country. Zika virus, we know that it's transmitted by the Aedes aegypti mosquito, of which we have fewer. We have more Ablopictus, but it is possible, it hasn't been documented, but it is possible that Ablopictus can transmit it. Dengue, after an incubation period of 3 to 14 days, you get a high fever, very characteristic, severe headache and retroorbital pain. Severe arthralgias and myalgias, and hypotension is not unusual. They develop, 40%, 50% develop a diffuse either morbilliform rash or a sunburn-like toxic shock type of rash. And they have a high viremia for about a week to 10 days. Usually develop a leukopenia. They may develop thrombocytopenia. Some patients, depending on the severity of the illness, they may have a positive tourniquet test, which a tourniquet test is you put a blood pressure cuff on the arm, inflate it to halfway between systolic and diastolic blood pressure, and then leave it for 5 minutes, and then release the pressure. And if there's a development of petechiae below that area, that's a positive tourniquet test. Thrombocytopenia, quick bedside test. The risk of hemorrhagic fever rises as the patient seems to be getting better, so that's when you really need to keep an eye on the patient. Chikungunya, less than 14-day, again, incubation period. They have fevers, they have very severe myalgias and arthralgias, swollen joints. They may get a morbilliform rash, maybe 40% may get a morbilliform rash or a diffuse rash. They have a very high viremia very early, and it goes down by about a week, and it lasts up to 10 days, thereabouts. The arthralgias, as you know, may last for months. Now, Zika virus is a little bit different. The incubation period, again, is less than 14 days, but most people have no symptoms. 80% of people have no symptoms. So most people walk around with Zika virus, never know that they had it. Of the people who do develop symptoms, besides the fever and the arthralgias, they will develop conjunctivitis, which may be a distinguishing feature. Again, the morbilliform, same rash. And they actually have a much lower viremia than the other viruses, and it goes down pretty quickly. It's a shorter duration of illness. So you have a patient that you're evaluating with a morbilliform rash. This one is Zika virus. There's a conjunctivitis that you might see. You might see conjunctivitis and measles, so bear that in mind. Typical morbilliform rash. All right. You might see any of these as well. So it's going to be very difficult to distinguish a lot of these possible infections just on the basis of the rash or the pattern of the rash. We've got dengue, the hemorrhagic conjunctiva, which may mimic conjunctivitis. There's dengue, Rocky Mountain spotted fever, which happens all over the world. Okay. So keep your differential diagnosis broad. What to do then? You suspect this patient has one of these viruses. I'm happy to have the director of the Hillsborough County Health Department here. You would call our health department. There are some commercial kits that are available through Quest. They're not FDA approved, so you're going to want to go through the state lab and CDC. You can do, if it's early on, you can do an RT-PCR, and later on they'll do serology, which is more sensitive. They also do spinal fluid, tissues, urine. I'm not sure about saliva. I know VA is trying to set up for saliva also.
For the acute cases, we are testing saliva as well as urine. Actually, seems to be the best right now.
All right. So there is an algorithm for testing. You have to give them the date of exposure, the date that you drew the specimen, and that will determine which tests they're going to do and what follow-ups. There can be a lot of cross-reactivity with the serologies and some of the PCR, so there's a lot more backup testing that gets done as well to confirm. So how do we advise women who are pregnant or planning? CDC recommends avoiding or deferring travel, if at all possible, to Zika-prone areas for men and women if there's a possibility of pregnancy. Any men who have lived or traveled at any point in the during the recent epidemics should use condoms or abstain for the duration of pregnancy, because we don't know how long the virus will shed in semen. And this is the short protocol for a woman who has had a history of travel to a Zika-prone area, but she's not symptomatic. You can screen with IgG ELISA, and it's a much shorter algorithm. You don't necessarily need to do serial ultrasounds unless you suspect that there's an inconclusive or a positive test. And of course, you're going to verify that with PCR. There's there's neutralizing antibody testing that they can also do, is maybe a little bit more sensitive, but not available other than at the CDC. If there's a pregnant woman who lives, if you are in an area where Zika virus is circulating, the algorithm is crazy long. And you do serial ultrasounds and you do serologic testing at different points in the pregnancy. And that also is evolving. So you don't have to remember any of this that I just told you, because the CDC has excellent online resources for evaluating the individual with dengue type of illness. Also for pregnant women, a lot of very good advice, and all of it is changing on a daily basis. So check before you do anything. All right. So how do we get here? That's how we got here. All right. So why haven't we been able to eradicate this problem? And the problem is mosquitoes. Well, we tried very, very hard in the 1960s in South Florida, and we made some really good inroads. We did the fogging, the trucks were everywhere fogging, and we're pretty much back to the beginning. So the range of these mosquitoes, Aedes aegypti, is generally South Florida to Texas, southern U.S. The Albopictus has a much wider range, goes much further north. It prefers cooler temperatures. So fortunately, right now, as far as we know, it's not as well transmitted by Albopictus as it is by the Aedes aegypti mosquito. We do have some questions about that, though. That is a very big concern, because there are several different species besides those that can transmit Zika virus and the other arboviruses. And in other different parts of the world, there have been documented transmission and outbreaks related to Aedes albopictus. So it may be local factors, it may be locally adapted species. It is possible, though we don't know, and hopefully we don't think so, that Aedes albopictus will become a vector for Zika virus here. All right. The Aedes species, why are they such a problem? Well, they pretty much evolved with humans. They evolved to lay eggs in water vessels, and they're highly adapted to that. They prefer to live around humans, especially Aedes aegypti is an urban mosquito. It lives indoors and outdoors. It'll hide out in closets and be really happy until somebody walks by. They actually do not need blood to survive. They can feed on nectar, but the females need blood in order to produce eggs. And the other thing about them is that when they lay eggs in water-containing vessels, if they dry out, they can survive for months. And the next time there's a rain or somebody fills the pot and leaves it there, they'll be breeding again. All right, so if you eradicate all the mosquitoes in an area, the Aedes mosquitoes in an area, eggs and everything, or you try, because you can't actually find the eggs most of the time. You'll have no mosquitoes for 2 weeks, and then you'll have a resurgence of the population of mosquitoes. They can lay eggs in tree holes. They can lay eggs in very small amounts of water and have larvae survive. So use your imagination. Wherever there might be a little collection of water, that's a possible source. And that's a health department slide. That's all it takes. There has been a concern also from entomologists that rising temperatures are playing a role in the rapid dissemination of these viruses because the mosquitoes develop and reproduce much more quickly with higher temperatures. They prefer, Aedes aegypti especially prefers higher temperatures. So their maturation to breeding capacity is much faster. The development of the virus from the gut and transfer into the salivary glands is much faster, so they can reproduce more mosquitoes and transmit faster. There are some experts that suggest that maybe it's related to heavy rains recently in Brazil, that they had just everything came together. It was a perfect storm to create an outbreak. All right, so what are the controls? The most effective control is still the control of habitat. So any standing water, and it's not necessarily just the mosquito control folks that need to do it. We all need to do it. Make sure that you clear out or turn over any pots, anything that you can see that might contain water. Mosquito control programs, the president yesterday requested $1.8 million in emergency funding for mosquito control programs, and hopefully that will be an ongoing investment because mosquito control programs have been terrifically reduced in the last couple of decades. But here in Florida in the last couple of years, the state funding of mosquito control programs has been halved by about $1 million. So there's been less mosquito research, there's been less lower staffing, so less attention to that. Mosquito control, as you might imagine, is a very labor-intensive, time-intensive process. We used to fog way back in the 60s, but that doesn't work nearly as well as trying to contain the breeding sites. Mosquito avoidance measures, long sleeves, the insecticides and the insect repellents are safe in pregnancy, so those are recommended. There's some biological measures that are being investigated, like mosquito fish, putting mosquito fish in standing water, releasing genetically modified mosquitoes that produce flightless offspring. That's a temporary fix that would have to be redone a few times, but that's been successful in some areas in Brazil where it sharply reduced the populations of mosquitoes. And there's some investigations into actually infecting mosquitoes with bacteria that affect their reproductive capacity. So Wolbachia is a bacteria species a couple of different species are being investigated. Vaccines, of course. They're hoping to develop a vaccine within the next couple of years. We'll see how that goes. They're looking at antivirals, just like HIV, protease inhibitors, nucleoside agents. All right, and then, for at least from now until we know more, there needs to be more attention, especially in poorer communities where people don't have as much air conditioning or attention to screens or health care. We need to improve our ability to deliver reproductive health. All right, and the CDC has a really nice microsite right now for Zika virus, and pretty much everything you need to know as a clinician is right there at a point and click. So, and again, it's being updated on a daily basis. So I strongly recommend that you use that as a resource. That's what I'm doing. And we'll know more as the days go on. And I'll take any questions.
I read this morning that the CDC is still puzzling over the microencephaly, that it may or may not be Zika. And you gave a number of 3,900, I believe, in Brazil since October 15, but you didn't say what the denominator is.
Yeah.
Is that a normal rate, or is that a hugely inflated rate, like more than?
Yeah, well, based on, right, based on their estimates from,
Pregnancies. The
Yeah.
3,900 is representative of how many pregnancies?
right, and no, I don't have that number. The rate said, based on their public health estimates is, they usually would expect maybe 1 or 2 per 10,000 births, and it seemed to increase to 20 per 10,000 births. Whether that's just something spurious, we really don't know. We're just going to have to follow over time and see what happens. And there are some outbreaks elsewhere where they're not seeing microcephaly. Is it that particular strain of virus? Is it that particular area, that population? There are so many unknowns.
What about French Polynesia? That should be.
Yeah. No, the main thing that they observed was Guillain-Barré. That was, they didn't see a whole lot of microcephaly. That's been a recent development.
So it sounds like almost half don't present with a rash or conjunctivitis. So they present as just a flu-like viral syndrome. So I could see, with the public and with primary care physicians, when there's a flu outbreak and there's all this in the paper, both the
Right.
doctor and the patient are going to wonder about this from a practical standpoint. If they haven't been traveling, I guess you're not going to flood the health department with all kinds of requests. How do you take this from a very pragmatic, practical approach?
Well, the focus right now is still on travel history. And there's intensive screening, daily, actually, reports of how many cases they have that are travel-related of Zika virus. So I expect to hear a lot more from the health department as we learn more day to day. But the focus right now is on travel history. If there's a travel history, then that risk is elevated.
So if I call Doug and the patient has no travel history, I guess he's going to tell me don't bother to send the patient there for a test, I would assume.
Yeah, at this point in time, let me talk about some what ifs if they had somebody who had just returned with known or very likely this virus and check the sex, you can start thinking a lot. But most of that is all going to be in symptomatic people, even though we understand that there's a large amount of asymptomatic. We're still just looking to run the test on those that do present symptomatically. And that's just a supply issue. And then the focus is on pregnant women as much to help them and their obstetricians figure out the best way to manage them. It's a very focused cohort that's going to go on. The fear that the United States, the Florida, everybody else is that if Zika virus became endemic, or at least frequently enough here, that we could see some transmission, maybe as sporadic as we're seeing with dengue after a few years. That would still make it pretty anxious that by pregnant women, that's just another potential possibility, although maybe very small. It's enough to how you feel and think. So that's where.
Brian, did you have a question?
Yes, thank you for a wonderful presentation. I have actually a very simple basic science question. I think I heard you say at the beginning that there were cases of Zika virus reported back as far as 1954. How do we know that?
They cultured. They did cultures. When they first identified it in apes, that was they identified it at the Zika station, which is a yellow fever research station. So they were looking for yellow fever, but they didn't find it. There was something else. So that's where they were able to identify this previously unidentified virus. So, yeah, at that time they didn't know about any sort of human transmission. It was only a few years later in Nigeria where people were having this rash and jaundice type of syndrome, but didn't have any of these other viruses. They looked for Zika virus and they cultured it.
So one comment, one question. The comment is that there's now also a recommendation that if you've traveled to Zika areas not to donate blood. So that's the comment.
Yeah.
The question is, so say if you're an internal medicine intern, you're admitted a patient that this is part of the differential diagnosis, maybe a fever, a rash, and conjunctivitis. What kind of isolation do you want them to be in?
Going back to the transmission, it's not person-to-person airborne. It may be sexually transmitted. We don't condone those things in the hospital. So
It's all ideal.
So no, good question, because that's going to come up. So it's not going to be contact. It's not going to be airborne.
Would you wait until the measles is rolled out if that was a potential?
Yeah, if you suspect measles, if the vaccination history, again, travel history and vaccination history, you would want to hold off.
If somebody wanted to be infected with Zika virus, how long, do we know when it's safe for them to become pregnant? How long
We're not entirely sure. I mean, so far, the duration of viremia is about a week, maybe less than 2 weeks. What they're saying is once there's no evidence of viremia, once that's resolved, then it's safe. So probably 2 weeks, but I'm sure there's going to be more and more guidance on that.
The same question then for an infected man. Longer than 2 weeks, right? Because we don't know.
Yes. Right. Yeah, the recommendation is if you have a partner who potentially may become pregnant or is pregnant, use condoms and use them properly until the pregnancy is over. And, that guidance may change. But
Extrapolating from the Ebola issues, we didn't know that it could reinfect the same person in the eyeball, and the poor guy's eye color changed. So, Dr. Gompf is just reiterating again and again, more information will come out, and there'll be updated guidelines to be found on the CDC website.
tomorrow there's going to be something new.
How about the idea of the fluid? Is that a tool that you can use, especially in pregnant female?
Yes. Yes. If she has a history of a possible exposure and a positive serologic assay, then yes, that is recommended, or to consider amniocentesis. That is a fluid that can be tested for either PCR. It can be tested using ELISA and the neutralizing antibody assays, which are a little bit more sensitive and specific.
Just another question, have they described any microcephaly cases where they were Zika negative, just to see?
Yeah, they do have their certain baseline. So, I haven't seen a published number, but yeah, there were.
On the prevention side, do you or anyone else happen to know if those little bracelets actually work for preventing mosquitoes?
Ones that are supposed to get.
For older people,
Yeah.
like my mom, for instance, just make sure she always has bracelet on or something?
Well, the biggest concern, of course, is women of childbearing age. Most people will not have symptoms. If you do have symptoms, it's a very, very self-limited infection, and there haven't been any major issues. I'm not going to tell you that there have not been any fatalities in the very young and very old. We don't know, what percentage of that is going to be a problem. But what the CDC recommends is the commercially available insecticides. DEET is very effective. Oil of lemon eucalyptus is very effective. Picaridin is very effective. Basically, that's what they're referring people to use, including in pregnant women. They're very safe.
A comment along those lines, and Sandy, thank you for framing this in the context of mosquito-borne diseases, because we're dealing with so many other, of course, Chikungunya, Dengue, and now Zika virus. But there's an interesting debate now about whether we should bring back DDT as a mosquito control agent. Many of you are familiar that DDT was used for decades and was banned in 1972 by the EPA over environmental and public health concerns. Now that issue is being re-explored. DDT is still used in some parts of Africa for malaria control. It's a very effective mosquito control agent. So those of you who are interested in public health, pay attention to the DDT debate, because there's a lot of environmentalism, there's a lot of public health concerns, and it's a very fascinating debate that's going on now with all these mosquito-borne diseases.
And actually, that debate started with bed bugs. That's how we used to kill bed bugs. Bed bugs have become very resistant to permethrins.
Follow up, the one message you, Dr. Gompf, talked about is how local this mosquito is to your own residence. So you really command control over your own environment much more than a lot of the others. So it applies, you're not going to really spray your way out.
Right.
You want to spray enough.
So
You would have to poison us. Yeah.
Swimming pools?
No, because they're chlorinated.
If they're not chlorinated, I guess. I don't know about the salt. I don't know about the salt water.
I don't think they can survive. I don't think the larvae survive in salt water.
Aedes aegypti does not like swimming pools.
It's chlorinated. It's like fish. You can't put them in there.
There was a big problem with the foreclosures and housing. A lot of pools that